Okay, it's my pleasure as we move on to introduce my co-chair, Dr. Andrea Weghofer, who will be speaking to us now on the controversy about the relative relevance of thyroid function and thyroid autoimmunity for IVF success. Dr. Weghofer is an associate professor of obstetrics and gynecology at the Vienna University in Vienna, Austria. Andrea.
Thank you very much, David. Good morning, everybody. As an associated member of the CHR family, I'm really grateful for the invitation because it's a pleasure to be a part of that exceptional meeting. No conflict to declare. During the last days, we got an impression on how many efforts are made to improve clinical outcome in our patient population. And one of the controversies we are facing in the aim to reach that goal, we try to see what else we can do to maximize pregnancy outcomes. And the thyroid came up as one of that, probably among the most controversial issues, saying like, does the thyroid have an impact on clinical pregnancy rate? Do we need to have a look at it? And in order to answer that question, it always makes sense to go back to the basics, to see what we already know and to build on it. And when we go back to that, we definitely see, of course, the thyroid has an impact on pregnancy and live birth. As we all know, the thyroid is important for the brain development of the fetus, and it makes sense to monitor the mother's thyroid function just in order to see whether she's able to provide sufficient thyroid hormone concentrations until the fetus is able to produce enough thyroid hormone all by itself. Going a little deeper, we need to ask ourselves, what's the contribution of thyroid autoimmunity versus thyroid function on that issue? Do we have to consider both? Are they somehow related? What's behind it? And again, going back to physiology, when you have a look at thyroid autoimmunity, you realize that the immune cells, the CD helper cells, the B cells, they finally induce apoptosis, and not initially, but in the end, increased tissue damage of the thyroid. So that would assume all the thyroid autoimmunity that exerts its negative effects is mediated via the thyroid function. But we need to keep in mind that we have a lot of autoimmune conditions, and Norbert is going to elaborate on that have an impact on infertility without changing hormone concentrations. Lupus, whatsoever, antiphospholipid antibodies. And yet, they do have a negative impact on our reproductive potential. Because nature is fair, the embryo does not to 100% resemble the mother. So we need to induce a tolerance to accept the embryo and to enable it to grow to term. So the question is, does the mother's immune system accomplish the goal of inducing that tolerance? And what happens if she doesn't? T-regulatory helper cells are crucial in that in order to suppress the autoimmune system we have and to induce that tolerance. If the body is able to accomplish that goal, we are more or less happy with it. If not, we have issues with infertility, but the more we have issues with miscarriage, prematurity, and preeclampsia. So, in order to see what's going on between autoimmunity and miscarriage, it makes sense to just have a look at those women with normal thyroid function to address the issue of autoimmunity. And the recent review that was very nicely performed did so, saying like, okay, we're just including women with normal thyroid function with and without thyroid autoimmunity and see what's going on. And what they found was there was no impact on infertility or on the probability of getting pregnant, but we had a substantially increased miscarriage rate. So if tolerance is not induced appropriately, the chance to go to term is reduced. And if that is true, we should see the same effect in live birth rates. And Busnelli recently did, saying like, okay, we really have an issue with live birth rates to clinically, to a significant extent, with a probability decreasing by roughly 25%. So the question remains, what can we do with those patients? And recently, the hormone supplementation of thyroids that was established in Europe quite a while ago has made it to the United States, saying like, well, it may help our patients with thyroid autoimmunity, even in the matter of fact that many of them have normal thyroid hormone levels. It may still help them to supplement with levothyroxine. So thyroid autoimmunity may indeed increase miscarriage risk and live birth, and it would be helpful to supplement just in order to give the patients the benefit of a live birth they would be able to expect without thyroid autoimmunity. But when we think about supplementing as a therapeutic option, the question arises, what are we going to do in those women without thyroid autoimmunity? We know autoimmunity is more common in women that face infertility issues, but nevertheless, the majority of patients doesn't have autoimmunity. Do we still care then about thyroid function? Is it related to pregnancy potential, to infertility? And how should we proceed with those patients? Again, going back to physiology always makes sense to understand the process of how the thyroid may have an impact a little better. And yet, when we go back to physiology, it seems to make perfect sense because thyroid hormone nicely intertwines with FSH on the granulosa cell level in the oocyte, as well as it has an impact on the endometrium. And we've heard a lot about the mitochondria these few days. And again, thyroid hormones also influence the function of the mitochondria. So one may ask, okay, thyroid hormone may have an impact, but why on pregnancy? Men have thyroid hormones too. Why do we have an issue? We have about a 5-time higher prevalence of thyroid hormone diseases or thyroid disorders in women. So is there something more we need to address? And yes, apparently, because we have an interaction with estrogen. The more estrogen levels rise, the more likely they are bound to thyroid globulin, leaving fewer concentrations of thyroid hormone for the end organs. So that certainly raises the question, if someone wants to get pregnant, if someone is pregnant and estrogen levels rise, would it make sense to supplement even those that have normal thyroid levels in order to boost that, in order to give them the chance to optimize their reproductive system? And recently, a very nice review addressed that issue, saying, well, wouldn't it be nice to address, to supplement everybody who is desiring pregnancy to get TSH levels below that cutoff of 2.5? And in the general population, Ploden and co-workers said, that's not necessary, guys. That doesn't really make sense to supplement everybody. And if we have learned one thing during the last few days, we have hopefully learned that it doesn't make sense to do one treatment option for everybody, but to individualize treatment. Individualizing treatment means having a different look at the ART patients. And during ovarian stimulation, we know estrogen concentrations rise significantly. And even in those patients that are very, very well controlled endogenously, with a mean TSH of 1.5, and you know the upper cutoff is 4.4, even those women have a quite high risk to go until the upper limit of normal, and you can imagine what happens to those that do not start out with the 1.5 cutoff during ovarian stimulation. And when you want to address whether that really has an impact on pregnancy potential, it always makes sense to go to the best prognosis patients, which are, of course, the donors. And here we get a quite clear picture. When we compare those donors with really very good TSH levels below that cutoff of 2.5 to those with normal and upper normal ovarian thyroid function, it makes sense to see that. But though the numbers are small and you see significant differences, you may notice something else. There were not only normal TSH patients included. Some of them were hypothyroid. So one may assume, okay, we know if someone is hypothyroid, it might make a difference. But what happens to those if they're really normal? So they did a subgroup analysis just including those with normal TSH levels. And remember, those are young, healthy, fecund people. And still, the differences hold up. It makes a significant contribution to pregnancy potential where you start with your thyroid function. But in the end of the day, we're not only treating donors. Our patients are usually in their late 30s, beginning 40s. They have significant fertility issues. And it makes sense to have a closer look at them before making a final decision. And in the end, we always try to figure out a hypothesis, saying, okay, thyroid function, estrogen, whatsoever, why should it have an impact on those poorer prognosis patients at all? If the thyroid really has an impact on pregnancy potential, it should have an impact on oocyte development and possibly on oocyte recruitment. And by that, differences in the thyroid hormone should reflect AMH levels. And that's what we did. We took our patient population and tried to realize, does it make a difference in women with normal thyroid function, whether their TSH levels are within the optimal range of below 2.503, or whether they have higher normal TSH levels. And what we found was quite significant because, as you can see, AMH levels differ considerably. Probably the most important thing is that it makes such a huge impact in those women that do not have a lot of oocytes to optimize whatever we can do to reach the maximum pregnancy potential. And that was accounted for in another meta-analysis saying, well, does it make sense to supplement those women with levothyroxine? We have few side effects. It's easy to monitor and quite cheap as well. And they said, yes, well, it does to a significant extent. As you can see, effect sizes are pretty impressive on what we can achieve. And when you see how we struggle to increase pregnancy potential by just a few percents in those women, it makes sense to do whatever we can to optimize their pregnancy potential. So in the end, what is the bottom line? It comes down to that TSH cutoff of below 2.5 may not be the goal at the end of the day for everybody, for the fecund, young, healthy woman without any fertility issues. But in our patient population, it really may improve pregnancy potential and live birth rates. So by that, I thank you very much for your attention.
We have time for one or two questions.
Andrea, many thanks for your nice talk. Does it make sense to monitor TSH during stimulation? Because in the first 3 days of the period before we start stimulation, we check TSH. And afterwards, sometimes if we check it together with E2 on the day of triggering, we see it goes up. So do you suggest that we should monitor TSH or not? Thank you.
Thank you for that question, Kazem. As you know, TSH takes a while until we see effects, and I think what really makes sense is to optimize levels before we start. It doesn't make sense to monitor TSH like every other day during stimulation because we know what's going to happen. As you said, it increases with stimulation. But I think it makes sense to have a careful look before we start the stimulation, just in order to optimize everything we can do.
Please.
Do you think that adding up antioxidants like selenium or vitamin E, C, or E would make any change with the presence of anti-thyroid?
Thank you very much for that question. We have a lot of additional treatments like antioxidants, etc., just in order to optimize the ovarian microenvironment. And I think we have a close interaction with the thyroid here, and in my opinion, it makes sense, and animal models point towards that and underline that point, that it may be beneficial, particularly for those women who suffer from autoimmunity of the thyroid. Yes.
Okay, I think we'll move on in the interest of keeping to time.